Good morning and welcome to COVID-19 Talk with Local Health Authorities. Joining us from Harris County is Dr. Erica Brown, representing the City of Houston, Dr. David Purse. Special thanks to Kathy Finninger, past president, Rotary Club of Houston. Special thanks to our producer, Priscilla Key. I'm Stephen Williams, director of the Houston Health Department. Okay, y'all, we're winding down and getting close to that 100th show where we will conclude. But let's just do the last four, starting with this one. Transmission and current status. Is the viral burden in Houston rising?
So this is David first. I'll take that one because this usually leads into the wastewater discussion. And so we're seeing a significant increase in the amount of COVID virus in the wastewater. It's going up by about 30 or 40% per week. So right now we're at about 349% of that July 6th, 2020 value that we use as the reference. Not surprisingly, we're also starting to see, following on the wastewater, we're starting to see rises in positivity, whether you look at the city of Houston's or if you look at the Texas Medical Centers or if you look at the Harris County the data, they're all showing increases in positivity rates. And then most importantly, we're also seeing the increases in the hospitalizations. And again, remember, these lag a couple of weeks behind the increase in wastewater. So now the number of folks that are hospitalized with COVID are way, way less than what we've seen before. So we're starting from a really low point, but they are going up. And the other kind of good news is that the majority of the folks that are being reported as having COVID at the hospitals are being admitted for something else, but are testing positive for COVID. About 20% of the admissions are because of COVID. The other 80% are instantly found, but we can probably expect those percentages to keep shifting with more people being admitted because of COVID, as we've seen in the past. So,
respiratory illnesses like COVID, RSV, and the flu are filling hospitals, as David just told us. Also, rhinovirus and enterovirus are the numbers increasing, and what is the caution? Are we ready for another surge?
So yes, as Dr. Purse just mentioned, the numbers are rising, but not nearly as high as we have seen in the previous years. The difference this time is that we're seeing a flu spike and an RSV spike earlier than we would have previously seen, along with we're not finished with the COVID pandemic. We have holidays coming, beginning with Thanksgiving. So families are gathering, friends are gathering, and people are just out and about for the holiday seasons, which is contributing additionally to spread when we don't have as many preventive measures in place that we had. People are not wearing masks as much. Our booster vaccination rates for the COVID virus are below the national averages. It is flu season, so we should be getting our flu shots. All of these things that we would be doing to protect ourselves and did do to protect ourselves from COVID, some of those we've gotten a little bit lax about, and so we are seeing some increases in the numbers. As far as what we can expect, the next holidays are coming, and so we are fully expecting to continue to see the numbers rise. I don't think to the levels that we saw in previous years, but we are expecting to see them rise. The staff within our hospital systems and our healthcare systems, we are experiencing some shortages. And when we have this triad of COVID, RSV, and flu, it is going to be challenging for all of the staff to care for patients in need.
You anticipated my follow-up question, and your answer was we're still in a pandemic.
We are.
What information is available for the new BQ 1.1 strain of COVID? It seems to be 4 times more resistant to vaccines.
So BQ1 and BQ 1.1 are the new variants that are taking over. And remember, a variant takes over because it spreads more easily than the one that was in the neighborhood before that. So that's what's happening. Now, these are members of the Omicron family. So the booster, the bivalent booster, had protection against the Omicron BA.5. It's early now, but the data is starting to look like the bivalent vaccine is not providing the level of protection against BQ1 and BQ 1.1 that it did against BA.5. But let's keep a couple of things in mind. Number one is when the mRNA vaccines came out with a over 90% efficacy rate, that is extremely good. So we don't need to get comfortable with that being the norm. That is not the norm. There's an extremely high efficacy rate for a vaccine. I don't want to put a number on the efficacy rate for BQ because it's a little bit too early. I've seen a couple of reports and the numbers are they differ from one report to the next, but it does look like that's probably not as effective. But what is interesting is of the people who were vaccinated with the bivalent and then caught BQ, whether it be 1 or 1.1, they're having a very robust response in their immune system to the BQ. So we don't want anybody to go out and get sick, but for those who got the bivalent, they are having a very robust response compared to those who were not vaccinated at all, providing them greater protection going down the road.
Camels are one of the intermediary hosts for MERS. Many U.S. citizens rode camels during visits to Qatar and the World Cup. Is MERS a variant of COVID?
So no, MERS is not a variant of COVID. So there are many different SARS viruses, which frankly had been around prior to the COVID variant of SARS. And I'm not sure that this is one, but MERS is not related specifically to COVID, although it is a respiratory virus that does have similar symptoms. The good thing about MERS, though, is that protection from MERS is really through standard precautions. So good hand washing, hand hygiene, covering your nose and mouth. Certainly, if you're sick, to stay away from people. And now that we have gone through much of the protection measures with COVID, to wear a mask if you're concerned about it will protect you against a lot of things.
Our Harris County jails are overcrowded. Can you give a report on the incidence of COVID infection among jail prisoners?
So, I'm going to start this answer. Dr. Brown may want to chime in because she's got a lot of direct experience with it. But let me just say a couple of things about the jail. I don't have any current numbers on the jail. We have a team that works with them, and generally I get alerted when there's a problem, and I've not been alerted recently, so I'm going to assume that they've got things as under control as can be. But I really do need to shout out to the jail medical staff, and Dr. Brown was part of that back in the beginning, and they did a tremendous job. It is an overcrowded jail. It was a situation at tremendous risk for a horrible outbreak and lots of problems, and it never developed. Did they have COVID there? Yes. Have they had deaths there? Yes. But not to the level that we're seeing in some other jails across the United States. All the potential, and it is a constant struggle, but they have really been able to keep pretty much a lid on that. And to answer the question, I'm not aware of any problems there because I would get alerted if there was, and I haven't been alerted lately. But Dr. Brown, you worked there, and kudos to you and your team when you were there. But I don't know, you may have some insight. You work with them. Maybe you have something that I don't know.
No, I think you've answered the question perfectly, David. The possibility for outbreak is enormous in a congregate setting, and they do a phenomenal job above and beyond to protect not only the employees but the inmates as well from all infectious disease. They really have done an extraordinary job, and again, to my knowledge as well, there is not an increase in the jail.
Yeah, certainly kudos to you, Dr. Brown. You were our chief public health strategist that we recruited to come and bail us out. So maybe they're just doing what you told them to do. continuing to do what you told them to do. Can you comment on the public health risks of the sports events with masses of spectators and no masks? Certainly we witnessed that.
So I think this is no different than the conversation that we've had in previous questions. Any group, especially during this time, any gatherings bring risk. And so we have to be really careful to weigh our individual risk given our comorbidities in going into gatherings. The one thing that we can the one thing that we can guarantee is somebody in the crowd has something. That's just a guarantee. And so you have to, again, weigh your individual risk of catching something, whether that be COVID, whether that be RSV, whether that be the flu. Our recommendation is to take all precautions. Get your flu shot, get your COVID vaccines and your booster. Are they 100% effective, as we've discussed? Probably not. But do they prevent against severe disease and death? Absolutely. That question has been answered time and time again. For those who have some chronic medical conditions, something to consider. If you're going, we understand it's been a long road. It has. It's been a long road. And we understand the psychosocial impact of us being in isolation. But wear a mask then. Put a mask on. Be careful about how many people you're around. If you're having gatherings at your home, there are home tests available. Perhaps you ask your family members and your friends to test before they come. So just some things that we can take into account as precaution. It will never be 100%, but it's a given that in mass events, there is going to be some type of virus floating around, and we can't say whether you will be affected or not.
Yep, I'm a witness to that as of last week. What are the ambulance and ER personnel protection protocols on a patient with fever and a recent travel history from Uganda, site of recent Ebola deaths?
Yeah, so with the Houston Fire Department, we've got a pretty well thought out protocol, and most of the EMS agencies around the region have got similar protocols. But I think it's important that the person who writes this question understands there's two sets of situations. One is there are folks who've traveled from Uganda that we are aware of, and we've been notified by the CDC that they're in our community and that they are at either no risk or low risk. And right now there's less than a half a dozen of them, and the number changes almost daily as somebody comes in and we watch them for 21 days and then they drop off the list and so on. So we may get dispatched to a location where there's somebody who we know is on that list, or in the situation where they, for whatever reason, they're not on the list, we're not aware of them. When we get there and we find out that they've recently been to Uganda, and heaven forbid they were in Uganda to bury a loved one who was bleeding from their eyes, their ears, their nose, and bleeding everywhere, that would be the scary report. We have a very elaborate protocol. We try to minimize the number of people. In fact, we minimize it to 2 people will have any interaction with that patient. Our hazmat team gets involved. We pre-notify the hospitals so that they're prepared. When we get to the hospital, hazmat is there to help us, transfer the patient, decon our people, and it's a pretty elaborate process. And we are able to take care of critically ill patients or stable patients either way with this process. So we're right now we're of course we're always revamping these and re-looking at them. And the good news is that the situation in Uganda looks like it's headed towards being under better control than it was a month or so ago.
What is the percentage or numbers of doctors and nurse clinical workforce who must be quarantined because of workplace acquired COVID suspicion? Do we know that?
No, and so I think this is speaking to what is the recommendation? How would we manage this? So the latest, in the beginning of COVID, the recommendation was that anybody who was exposed also quarantine, not isolate, but quarantine and wait to see if they develop symptoms. Understanding the balance between the need to provide health care and in the workforce period and the effect of that versus the risk of spreading the virus, that's shifted a little bit and to where we are now, which is unless you develop symptoms. So let's say you've been exposed, unless you develop symptoms, you can continue to work. Certainly wear a mask and take all precautions, but you can continue to work.
How is transmissible disease in the homeless population?
I'll answer that, and we need to keep in mind something I think which is important. When we talk about the homeless population, I think most people generally in the general public get a picture in their mind of the people living under the bridge and panhandling. That actually is a fairly small percentage of the homeless population. Most homeless folks, individuals in the Houston area, are actually in shelters. And in fact, a shocking statistic is the demographic of the most common homeless person is a young woman with 2 to 3 kids in a shelter. So when you think of the homeless person, generally a male living under a bridge, that is actually the smaller demographic. Now, in the folks who are living under the bridge, they're living outdoors in tents, they're living outdoors. And so certainly disease can be transmitted across them, but that's not where we see the outbreaks of transmissible disease in homeless folks. We see it in the shelters. So right now we are actually monitoring the wastewater of multiple shelters. And as soon as we see that there's some COVID activity or what have you in there, we work with those folks and everybody inside gets tested, and we then are able to isolate and quarantine folks. And that's why we've not seen huge outbreaks of illness within our homeless populations. Certainly not the ones that are in the congregate setting, which is the high risk setting. The other thing about homeless folks that do live under the bridge, if you will, is that they get ill, they tend to not reach out for help. They take care of themselves. So to some degree, that never gets recorded. So that's makes it a little bit more difficult to answer this question.
Worcester Institute of Technology suggests COVID variants are still transmissible between mammals.
That is true. So there was a study done in bats, and it was thought that bats were the first transmissible mammal, the first host of COVID. And so there was a study done on the new variants, on the BA4 and 5 variant. And without getting into great detail, because frankly, I did not read the whole study, it does appear that the virus is still just as transmissible, even with the variants. And so there is an assumption made that among mammals, there is still high transmission rates.
Very confused about how to diagnose without a test. Flu comes on in 1 to 4 days and you feel miserable with fever. COVID comes on in 2 to 4 days and you can feel miserable. Early in COVID research, fever was considered a primary sign. What about now? Without a test, is there a probable symptom that will hint at what you have?
Yeah, this is a great question. This kind of comes to the art of medicine as opposed to the science of medicine. So the COVID tests, the PCR is highly reliable. The rapid tests, if you're symptomatic and you've been symptomatic for a couple of days, are pretty reliable. The influenza test, the bedside influenza test, unfortunately is notoriously unreliable when it comes back negative. If it comes back positive, you can count on it. But even people who have absolutely got the flu and have got lots of symptoms, the bedside point of care test, as we call it for influenza, is not terribly reliable. So it does become the clinician's, expertise in interviewing the patient, examining the patient, and trying to figure out what's going on. And I would just share a little anecdote. I remember in medical school, a very elderly physician standing on the stage and asking us how we diagnosed the flu. And, people started talking about this test and that test and PCR testing and all this sort of stuff. And he said, yes, but that's not the right answer. Yes, but that's not the right answer. And he finally said, when your patient wakes up and says they felt fine, but by noon they were so sick they thought they were going to die. And by 5 o'clock they were so sick they thought they weren't going to die. That person has the flu. And so anyway, sometimes it is the art of medicine because tests are not entirely reliable. And yeah, we go with that.
Baylor College of Medicine, Dr. Kloutman is predicting a surge. What does recent data tell you? Actually, you kind of answered that earlier.
Yeah. Yes, we are expecting to see a surge, not as high as we saw in previous years, but we're expecting a surge.
Can you comment on whether the nursing traveling workforce to acquire the ridiculously high salaries has gotten back to normal?
I'll take that one. I don't know that it's back to normal. When I talk to my colleagues that are in hospital administration, they are all very, clearly understanding what happened. And they are, unless they have to, they're trying to hire local nurses at normal, regular rates than the traveling nurses, because it's just a non-sustainable, fiscally non-sustainable situation. My understanding is it's not quite back to normal because we have a significant nursing shortage. And so anyone who is out there is listening, who is a licensed nurse, even if you were doing traveling, you made a boatload of money for a while, and now you're taking it easy, I would encourage you to reconsider that. Your community needs you now, and please consider getting back in the workforce. We really, really need you. And thank you for what you've done so far.
Vaccines and treatment, anything new?
So the most recent thing is the FDA amended the emergency use authorizations for the bivalent Moderna and Pfizer vaccines to include children down to 6 months. And so that just happened about almost a week ago now. And so now we have expanded use for both Moderna and Pfizer bivalent vaccines down to 6 months for children through the age of 5. So that's the most recent thing. David, I don't know if there's anything else that you want to follow up on.
No, I don't think so. The BQs don't seem to be responding to the antivirals, and that's going to be a challenge.
Relatives are visiting from Mexico. They receive vaccines not used in this country. The Cuban/Russian/Chinese COVID vaccines. What should be my concerns?
So, I don't think that the concern needs to be great. So these are vaccines that are used in other countries. I mean, they're effective. Again, when our mRNA vaccines came out with a 90+% efficacy, that's really uncommonly good. So the vaccines that were used in other countries, they're not bad. They just didn't happen to be as good as ours. So, if you've got folks who are visiting, it's the usual thing, watch for symptoms and try to protect yourselves as you need to. But their vaccines aren't bad. They just weren't as good as ours.
It seems that sue of plasma in hospital patients has stopped. Why the change?
So, as we've talked about in many of these discussions, the data continues to be evaluated and collected and evaluated on what is really efficacious in managing COVID. And so one of the things that was an earlier treatment was plasma replacement for those who were hospitalized with COVID and had severe symptoms. The data is now showing that is not as efficacious as they thought it was. It may still be showing that for those who are immunocompromised, severely immunocompromised, that there may be some benefit. So the current recommendation is not a to use or don't use. I think there's still research being done, but it does show that in people who are hospitalized for COVID who don't have severe immunocompromising disease, that it has not been efficacious. So the recommendation is not to use for those populations.
It used to be feed a cold and starve of fever. Should we just eat regardless since it's impossible to figure out what we have?
Please
Yeah.
do. Next,
Yes,
eat,
yes.
please.
Yeah, eat.
And when you're sick, we don't care what you eat. Just eat and
Yeah.
drink. Please stay hydrated.
When you have a fever, your body's internal thermostat's been reset and your metabolism is through the roof.
Yeah.
And I will share with you that, after 3 years, I've caught COVID last month for the first time, and I lost over 5 pounds, and that was with me still eating. Yeah, you need to eat. Your body needs that energy.
I don't know. I need to lose some weight, y'all.
That's not the way. Not that way.
Okay. Is the flu vaccine working well this year, as there seems to be numerous resistance cases? Dr. Tony Pedro with Baylor Vaccine Treatment Evaluation Unit recently noted that the most appear to be H3N2. Please explain.
Okay, so this is a lot. So I'm going to read my notes. Okay. So the Southern Hemisphere's flu has ended, and Chile found that flu vaccine is a good match for the current strain, which they said is 49% efficacious. The problem is that only about 24% of Texas residents have gotten the flu vaccine. So that's an issue. Hospital laboratories across Texas voluntarily report flu tests. So that's another issue just in terms of managing the data and what we're able to really discern. The flu in itself is not a reportable disease. So everybody who gets the flu, and to Dr. Peirce's point about those who may not have even had a test and just clinically you have the flu, there's a lag in data collection, and there's probably absolutely some gaps in data collection. Okay, so that being said, the most common influenza type is type A. A viruses are classified into subtypes, most common H1N1 and this H3N2. But only about 18% of the voluntary reported flu types were H3N2, which is appearing to be the most prevalent. But again, I do want to emphasize that there is absolutely a large gap in the data. And so we're not really clear.
Yeah. COVID tests are on a waiting list in some pharmacies in Houston. What's the holdup?
So I'll tell you, I don't know what the holdup is, because in some pharmacies there's plenty. And then the other thing is that the federal government just came out and said that they're going to reinstitute the thing where you can order free tests at home. I think that was just a couple of days ago. I've already ordered mine, and I would encourage folks to do that. So if your pharmacy is out of them, just go check another one nearby, or you can go to covidtests.gov and order some to be delivered to your home by the United States Postal Service.
In the news, POTS, a debilitating heart condition, is linked to COVID and to a lesser degree vaccine. It's just saying where it came. Reported in the Dallas Morning News. Any comments on that? Not really.
Not really.
Symptomatic COVID-19 infections associated with an increased risk of overactive bladder symptoms. Forbes. David?
Yeah, so that's true. There has been some reports. It's just the thing about this is not so. I mean, people are finding out that their bladder is a little bit more sensitive, and so they're urinating more frequently. It's a nuisance. It doesn't seem to be any terrible pathology going on, and it also, like so many of these other COVID complications, appears like it will go away if you're one of the folks who has the OAS, the overactive bladder syndrome, that it will eventually go away. But what I really think is important for the discussion here today is to recognize that COVID, this coronavirus, is different from most every other virus in that it has an ability to impact absolutely every single organ system in your body, whereas most viruses, there is an organ system that it prefers to bother. Like rhinovirus, the cold, it's your nose, your runny nose, you get stuffy, you sneeze, you get, it's miserable, and it's all pretty much in your face. Flu, body aches and cough and maybe sore throat, but it doesn't bother your bladder, doesn't bother your kidneys generally. But so this virus is unique in that there is not a single organ system that it will not take advantage of one way or another. So the bladder, just another organ system that, it causes problems there too.
Are there any concerning reasons that Mr. Musk is using a court process to get new and old information from Dr. Fauci? I'm not familiar with that.
I'm not touching that one. I will say this though, from a plug for public health. I think, regardless of who's saying who did what to whom, and we need to be very careful about misinformation versus scientific evidence-based researched healthcare fact, and making sure that we're protecting our communities.
Fortune magazine said the Surgeon General urged Americans to take precautions about viruses. You think? How? That's the end of those questions. I think that was just a comment. 3 more to go, y'all. So hang in there. Thank you for joining us for COVID-19 Talk with Local Health Authorities. Joining us was Dr. Erica Brown, representing Harris County, Dr. David Persh, representing the City of Houston. Special thanks to past president of Rotary Club of Houston, Kathy Finninger, and to our producers, Priscilla Key and Malik Goldman. I'm Stephen Williams, Director of the Houston Health Department. Thank y'all.